Everybody. Yeah. Good evening, everybody. And we'll be discussing one important thing about the univentricular heart. And as you know, the first step again starts with echocardiography before making any management decisions. And just let's go and start how we try to assess the univentricular heart and what are the important aspects when we try to decide the management options for univentricular heart. So what is actually a definition of univentricular heart? When you call, see again, not just you can see one chamber or two chamber. In fact, you may know that in spite of seeing two chambers, sometimes we may not be able to do a two ventricular repair. So we need to have a surgical definition when it's called as when there is an inability to establish two independent functioning ventricles to support in swelling. Second thing, it can be because of inadequate ventricular size and volume. So one ventricle may be small, other may be big. You may have two ventricles, but you have a lack of independent inflow. I'll tell you what I mean by that. And the third important thing is we have inability to establish adequate left ventricular outflow. So you have two ventricles, but you may not be able to establish adequate left ventricular outflow to generate a systemic cardiac output. In addition, in some situations, you have two good-sized ventricles, but you have some kind of a ventricular arterial malformation or conoventricular abnormalities in such a way that in spite of having two good ventricles, you are not able to make a two ventricular repair, and you may have to think about a univentricular repair in those situations. So which are the anatomical variants? Like these were the surgical variants. The anatomic variants, like classic, either tricuspid atresia or a mitral atresia. So as we said in the previous slide, we have a lack of independent inflow. So that comes either in tricuspid atresia, mitral atresia. So you have one inflow which is not adequate. Second thing, we have a situation called as an unbalanced AV septal defect. So your alignment or association of AV septum to the ventricle is such that you have one ventricle which is big because your alignment to the common AV wall is more towards one of the ventricles. That always happens that towards the right side. So you have a hypoplastic left-sided ventricle, and your most of the AV wall get attached to the diaphragm wall of the right ventricle, and you have an unbalanced AV septal defect. So eventually what happens that it's not possible to have a balanced two ventricle situation because your AV wall attachment is mainly to one of the free walls of one of the ventricles. Second thing, we have double inlet ventricles. We have two AV walls, but they are attached to only one ventricle. So eventually there is no interventricular septum. So you have a situation of double inlet ventricle. Then I said the variant of double outlet right ventricle with remote VSD. So in this situation, you have two independent ventricles. They have good sized ventricles, but your ventricular arterial alignment is such that you cannot connect left ventricle to the aorta without causing any obstruction. So in spite of having two good sized ventricles, we are not able to do a complete biventricular repair. The next is hypoplastic left heart syndrome. So it's a combination of multiple abnormalities. You have mitral stenosis or mitral atresia. So as a effect, as you know, embryologically when the ventricles develop, they always develop with the inflows. So your inflow has to be adequate to have a good sized ventricle. So in hypoplastic left ventricle, either you have a severe mitral stenosis or a mitral atresia. So eventually you have a very small size left ventricle and you have very small size left ventricular outflow tract. It depends upon what severity it is. But eventually what happens that you don't have two good sized ventricles to have a biventricular repair. In addition, hypoplastic left heart syndrome, you don't have a good LV outflow tract to sustain a good cardiac output. The last one is pulmonary atresia with intact ventricular septum. It can happen in combination with tricuspid atresia. So you can have tricuspid atresia, pulmonary atresia, or you have a varying degree of tricuspid wall hypoplasia. When we call it as a tricuspid wall hypoplasia, you know that we have to take the tricuspid wall annulus, calculate the z-scores, and when your tricuspid wall z-score is less than -4, eventually they are never, that ventricle, that is a anatomic right ventricle, is never considered suitable for considering a biventricular repair. You know, when we try to take tricuspid wall z-scores, more than -2, you know, the patient can undergo two ventricle repair. Between -2 and -4, it's always a borderline situation, and sometimes we may do something what is called as a 1.5 ventricle repair. But if the tricuspid wall z-score is less than -4, is never considered suitable for a biventricle repair. So your pulmonary atresia intact septum will have definitely varying degrees of tricuspid wall hypoplasia. So if you see all these situations, you have an abnormality of independent inflow which can sustain a good ventricle, or which hinders the development of a good ventricular size. So it can be either mitral wall which is hypoplastic or atretic. You may have varying degrees of tricuspid hypoplasia or atresia. So eventually you don't have a good size left ventricle, or you have a good size right ventricle. You have unbalanced AV wall, so your wall has attachment to one of the ventricle, more attachments to one of the ventricles. So eventually you have one ventricle which is large, another ventricle which is small, so can't sustain a good two ventricle repair. You have a very large VSD where both the inflows will go in one ventricle. So eventually you just have a small outflow chambers, or even no outflow chambers. In some situations, you have two good ventricles, but your VSD in such a location that your left ventricle cannot be connected to the aorta. So eventually, you do not have a good left ventricular outflow tract. So these are some of all these variations in univentricular heart, which will predict whether you can do a two ventricle or a single ventricle repair. And when we try to do echocardiography, we have to see all these variants in detail. Basically, we'll have to prognosticate the long-term outcomes, immediate surgical risk factors, and whether we'll be able to do all the stages for univentricular heart repair. So these are different anatomic variants. Now, what are the physiologic variants? We may have just balanced parallel circulations. What do I mean by balanced parallel circulation? Sometimes you might have seen a patient with double inlet left ventricle with moderate to severe pulmonary stenosis. So you have just adequate pulmonary blood flow, you have pulmonary artery pressures normal, you have a good systemic outflow. So eventually, many times when we see this kind of a patient, they have no symptoms. They may saturate between 80 to 90%. So this is just a balanced parallel circulation. And it's a difficult decision making whether we have to push these patients to a univentricular pathway. The second situation is significantly reduced pulmonary blood flow. So you have a univentricular heart, you may have a tricuspid atresia with significantly reduced pulmonary blood flow, and the patient will present to you with cyanosis, maybe oxygen saturations of 70% or less. And that may be because of inadequate flow, that is, you have a significant pulmonary stenosis, or obstructed flow, that is either the pulmonary circulation is atretic, so you may land up with a pulmonary atresia, or you may have pulmonary stenosis. The second situation, you have an excessive pulmonary blood flow. So you may have a patient which is univentricular heart, but comes to you with a heart failure. So sometimes you might have seen patients with univentricular heart with excessive pulmonary blood flow without pulmonary stenosis. So we have a double inlet left ventricle with pulmonary artery hypertension without pulmonary stenosis. So they present to you with heart failure. You have a tricuspid atresia 1C. So you have a tricuspid atresia without pulmonary stenosis. So they come with excessive pulmonary blood flow. So usually what happens, why they come to you, you have unobstructed or excessive pulmonary blood flow, like what happens if univentricular heart without pulmonary stenosis. The second situation is obstructed systemic blood flow. So you have an example of hypoplastic left heart syndrome. So in that situation, in addition to mitral stenosis, mitral atresia, are varying degrees of aortic stenosis, aortic atresia. So your whole systemic blood flow is obstructed. Another variant of this, if you have a patient with mitral stenosis or relative mitral, severe mitral stenosis or mitral atresia, but you have a significantly restrictive ASD, again that takes you as an obstructed systemic blood flow. Or you sometimes may have tricuspid atresia, pulmonary atresia, or pulmonary atresia intraventricular septum, but significantly restrictive ASD, because your whole cardiac output will just go through the restrictive ASD. Your blood has to go from right atrium, left ventricle, and to the systemic circulation. And if your ASD is significantly restrictive, that will act as an obstructed systemic blood flow. And the last variety is a ductus dependent systemic circulation, and that is typical of hypoplastic left heart syndrome. So these physiological variants in univentricular heart, we have just balanced parallel circulation, and all these things we have to identify them correctly on echocardiography, mainly because your surgical decision will depend upon what you say as far as these kind of situations are concerned. Because if you have a balanced parallel circulation, you don't need to hurry immediately. As compared to that, if you have somebody coming with severe cyanosis with an oxygen saturation of 13–40%, then we have to act immediately. Other side, if we have a heart failure with excessive pulmonary blood flow, you will have to act again immediately to reduce the pulmonary blood flow. If you have obstructed systemic blood flow, suppose you have a very restrictive ASD or a PFO, you have to immediately open it by any means to maintain the systemic blood flow. And if you have a ductus dependent systemic circulation, you will have to keep the ductus open. So these physiological variants have to be taken into account for decision making. Now, what is the general approach in patients with in univentricular heart repairs? What is the in general approach? We have to maintain adequate systemic perfusion and oxygen saturation. Suppose somebody is very blue, you have to make the oxygen saturation okay. You have to maintain adequate systemic perfusion. If you have a duct dependent systemic circulation, you have to keep the duct open to have a adequate systemic perfusion. Maintain normal ventricular function. So we have to prevent ventricular dilatation and hypertrophy, because we know that as eventually you have a single ventricle, and it's our responsibility to preserve that ventricular function. Otherwise, on long term, this ventricle may not function. So if somebody, any patient is excessively flowing or has increased pulmonary blood flow and pulmonary hypertension, we have to prevent dilatation. We have to reduce the pulmonary blood flow by various means like pulmonary artery banding or otherwise. We have to see the ventricle should not hypertrophy. If you have severe LV outflow tract obstruction, again it's a bad marker for a long-term outcome for single ventricle repair. Establish systemic venous to pulmonary artery connection and prevent and control the arrhythmias. So general approach for management of univentricular heart, we have to maintain systemic perfusion, oxygen saturation has to be maintained, the ventricle has to be preserved. We know we have to connect the systemic veins to the pulmonary artery at some period of time, and see to it that we should not have arrhythmias much, mainly because if you lose the atrial contraction to the ventricular filling, as it is, most of the ventricles in univentricular heart have some amount of a diastolic dysfunction. When you have diastolic dysfunction, your atrial contraction to the ventricular filling is very important for maintaining the cardiac output. And any period of time you develop atrial arrhythmias, you lose the atrial contraction and atrial contribution to the ventricular filling, and that will reduce or hamper your cardiac output significantly. So these are the parameters we have to keep it in mind when we take, and then adequate decision will definitely help us in adequate proper decision making at particular period of time. Now, when are the indications for in a univentricular heart when to intervene? And what are the indications for early interventions in general? And that has to be again defined, everything has to be defined on echocardiography. If you have a systemic outflow obstruction, that means you have a significant LV outflow obstruction. We have severe cyanosis, either with severe pulmonary stenosis or pulmonary atresia, or you have duct-dependent pulmonary circulation. We have excessive pulmonary blood flow, like you have a univentricular heart or a double inlet ventricle with severe pulmonary hypertension. And another very important thing which has to be addressed on echocardiography, how is your pulmonary venous rhythm? Because any kind of obstruction to pulmonary venous rhythm has to be addressed immediately, mainly because that will create pulmonary artery hypertension, and once the pulmonary artery hypertension sets in, they are very difficult subset for univentricular repair at any stage. So now I'll give you examples of tricuspid atresia pulmonary. These are the examples where we need to act immediately, and those things have to be defined on echocardiography. If you have tricuspid atresia pulmonary atresia, we have a double inlet left ventricle with excessive pulmonary blood flow and pulmonary hypertension. We have a mitral atresia with very small ASD or near intact interatrial septum, because we have to open the interatrial septum wide. We have a hypoplastic left heart syndrome with duct-dependent systemic circulation, and we have pulmonary atresia intact ventricular septum with duct-dependent pulmonary circulation. So these are all either duct-dependent systemic circulation, duct-dependent pulmonary circulation. We have a very restrictive ASD or a PFO in settings of mitral atresia. We have systemic outflow obstructions like hypoplastic left heart syndrome, and we have excessive pulmonary blood flow in patients with double inlet left ventricle with severe pulmonary hypertension. I'll just see how many videos can work properly. Now this is a situation, as I said, anatomic variant of tricuspid atresia. We see restrictive VSD and a functionally single ventricle. So this is one of the variant of a single ventricle. So I don't know whether it will work, but I'll just see. This is a situation which is, we see mitral wall which is atretic. We have a univentricular heart which is morphological right ventricle. You see the interatrial septum, if you carefully see, it's going on the left side. That means your left atrial pressure is very high. You have a restrictive PFO, and many times that needs to be opened immediately. This is a patient which you can see you have a hypoplastic left heart syndrome, you have a mitral atresia, significantly hypoplastic left ventricle, and a morphological right ventricle. In this situation, I'll just come to that later. It's very important to see what is the degree of AV wall regurgitation and function of the single right ventricle, because these are the determinants for a successful repair of a hypoplastic left heart syndrome, that is Norwood stage 1. Because if you have, in fact, from the fetal life, what are the risk markers or risk factors what we see in patients with hypoplastic left heart syndrome? We have to see how wide is the interatrial septum, because that tells you about the pulmonary venous hypertension. How is your tricuspid wall, whether it is competent or you have a significant AV wall regurgitation, and how is the right ventricular function. And in the immediately after birth, on day 1, day 2, you are assessing a baby with hypoplastic left heart syndrome, and you find all these risk variants like severe tricuspid regurgitation and significantly dilated right ventricle with dysfunction. You can counsel the parents accordingly, because these are not good subsets for Norwood stage 1, and that decision whether to go ahead for surgery or not has to be taken very carefully in this kind of a situation. Again, in this patient, this is a hypoplastic left heart syndrome. You can see significantly narrow left ventricular outflow tract. So these kind of a patients will have severe LV outflow obstructions, and those need to be addressed immediately after birth. So I don't know whether this works. Okay, this is a patient with actually a double outlet right ventricle and remote VSD, and even if you have 2 good sized ventricles, they are not suitable for a biventricular repair. So what are the early surgical palliations in neonates and infants in these situations? We need to do a systemic to pulmonary artery shunt in patients with pulmonary atresia, either it's a tricuspid hypoplasia or atresia with pulmonary atresia. We need to do a systemic to pulmonary artery shunt. We have to do pulmonary artery banding in excessive blood flow situations. In addition to pulmonary artery banding, we have to repair the systemic outflow tract obstruction. We have to repair the pulmonary venous return if there is a significant obstruction to pulmonary venous blood flow. And we may have to do atrial septicectomy if you have a significantly restrictive ASD. I'll just give an example. We sometimes have situations like mitral atresia, double outlet right ventricle with excessive pulmonary blood flow. So even if you do pulmonary artery banding, it will cause you a systemic outflow obstruction mainly because your interatrial septum is very restrictive. So we have to do a wide atrial septicectomy in patients with these situations in addition to pulmonary artery band. Actually, this is the patient. If you can see, these are the good sized branch pulmonary arteries, and this patient had tricuspid atresia, pulmonary atresia, and there was a shunt done to improve the oxygen saturation and for growth of pulmonary arteries. Now, this is a very important thing. This is a patient with double outlet left ventricle, and if you see carefully, this is a double inlet left ventricle. This is a outflow chamber, and from outflow chamber you can see the aorta coming, and this is a pulmonary artery. Now, if you do just a pulmonary artery banding, there is always a chance that this infundibulous septum with hypertrophy, and this is you may call it as a VSD, you may call it as a bulboventricular foramen, and there is always a possibility that this sometimes I do understand this. I don't know exactly what is happening with this video. Is just now. I know that, but it's not just working. And but I think we do not need. I just wanted to show you how we assess the bulboventricular foramen. And if you go to this Rebecca Schneider's book, you have to measure this bulboventricular foramen in multiple views in relationship with your aortic wall annulus. And there is a formula, I don't remember that formula, but you have to go and see the reference in Rebecca Schneider book. This adequacy of the bulboventricular foramen for univentricular heart repair is very, very important, because if a pulmonary artery binding is done in this situation because of the coronal septal hypertrophy, you may create a left ventricular outflow tract obstruction in this situation. And if you feel that this bulboventricular foramen is not adequate, we will have to do something what is called as a DKS operation, connect the aorta to pulmonary artery, then disconnect the pulmonary artery and do something kind of either a aortopulmonary shunt or this Stano shunt. So this adequacy of bulboventricular foramen is at most important in patients with double inlet ventricle with outflow chamber when your aorta comes from the outflow chamber. And you know, always in double inlet situation, double inlet left ventricle or ventricle situation, it's always a transposed great vessel. So your main ventricle gives rise to the pulmonary artery and the outflow chamber gives rise to the aorta. So this is a transposition situation always in patients with double inlet left ventricle. At the same time, it is actually, as I said, there was a restrictive bulboventricular foramen in this situation, and it's very important in this situation that you will have to see whether you have a adequate interatrial communication, especially if you are dealing with patients with mitral atresia or hypoplastic mitral wall leaflet. Even in patients with tricuspid atresias and varying degrees of tricuspid hypoplasias, it is very important that we have a adequate interatrial communication to maintain the systemic cardiac output. Now, this is immediate. As soon as you see a patient with univentricular heart, if they are significantly cyanoed, you do a shunt. If significantly overflowing, you do a band. If you have a pulmonary venous return obstruction, you have to relieve the pulmonary venous pulmonary venous obstruction. If you have a restrictive interatrial septum, you have to make the interatrial communication very big. You have a left ventricular outflow tract obstruction, you have to relieve that, and you have a duct dependent circulation, you have to maintain the systemic or a pulmonary circulation adequate. So this is usually an emergency surgery, and that has to be done in early neonatal life. Now you have stabilized the baby, and now you have come to a second stage of hemifontam. And again, what are the parameters on echo evaluations are very important. And one of the key factors on echo evaluation, either prior to or sometimes after any kind of a initial palliation like pulmonary band or aortopulmonary shunt, or sometimes you may not need to do anything because, as I said in the beginning, you may have a just adequate parallel circulation. So you have a double inlet ventricle with moderate to severe pulmonary stenosis, and you can directly come for a bidirectional Glenn, and you may not need either a shunt or a band, because we know in univentricular heart repairs, we will try to preserve the pulmonary artery anatomy the most. We know that after doing a band or sometimes by a shunt, there is always a possibility that your pulmonary arteries may get distorted, and try to preserve the pulmonary artery anatomy as much as possible. So pre-bidirectional Glenn evaluation, we have to see pulmonary artery anatomy. You have a good sized branch pulmonary arteries and your Z scores are adequate. Assessment of pulmonary blood flow, that is how severe is the pulmonary artery obstruction. You have, it's very, very, very important to see the presence of azygos. How is your, whether you have a IVC interruption with azygos continuation. You know, in this situation, we will have to do a procedure called as the Kawashima procedure, and we will not like to do Kawashima procedure in a very small infants or babies, because in that situation, not only is the SVC connection to the pulmonary artery, but you have most of the IVC return also goes through the SVC into the pulmonary artery. So we may like to delay Kawashima procedure beyond infancy many times. So presence of IVC interruption or IVC connection to the right atrium, whether it is there or not there, is one of the very, very important part of bidirectional Glenn procedure assessment. Then see whether you have a single SVC or two SVCs, then they will have to do bilateral bidirectional Glens instead of single Glen. It's a very, very important thing to say for a AV wall regurgitation, because that creates, that's one of the incremental risk factor actually. Because if you have a AV wall regurgitation, that turns into a ventricular dilatation, and the ventricle dilates over the period of time. We know that there is a possibility of a ventricular dysfunction. Are there aortopulmonary collaterals? As I said, size of interventricular communication in patients with double inlet ventricle, that is called as a restrictive bulboventricular foramen. And most important thing nowadays, when we have everything, what is the type of single ventricle? Whether it's a single right ventricle or whether it is single left ventricle, which again have its own long-term outcomes, and therefore. See, many times if you have a tricuspid atresia, it's very easy to say that you have a single left ventricle. You have a mitral atresia, you know, it's a single right ventricle. In double inlet left ventricle, many times, in 90% of the time, it's a morphology of a single left ventricle. But in some situations, we may have a indeterminate kind of a ventricle, or maybe sometimes a morphological right ventricle, because that helps us in long-term assessment, counseling the parents, how the whole single ventricle is going to behave on long-term. So if we can assess the type of single ventricle, single RV versus LV, and I'll tell you in a moment why it is important, because that tells you the long-term outcome. And therefore, in patients with hypoplastic left heart syndrome, when we have a single right ventricle, I think our counseling completely differs, because we know it may, there's a high chance that it may fail over the period of time. We don't know exactly, but it will not behave in the same way as the single ventricle behaves in tricuspid atresia when you have a morphological left ventricle as a single ventricle. So when we do a eco-evaluation of patients with for a potential univentricular repair, either a Glenn or a Fontan, these are the factors which are very important to assess. This is just showing you. It is very, as I said, I don't know why videos are not working, but I'm just trying to show you that try to see as good pulmonary arteries as possible, so that to see the Z-scores and see that they are in an adequate range, so high possibility that your gland will function better. Again, I'll just show you, this may work. No, again it's not working, sorry. But this is a picture which is, if you carefully see, there was a IVC interruption with the azygous continuation. This blue flow tells you it's a IVC interruption, azygous continuation, and the azygous goes and joins the innominate vein. So this is a patient which eventually will need a Kawashima repair. It's not only the gland. So it's very important to show that the IVC drains into the right atrium and there is no evidence of IVC interruption. Now this is a still image. Again, you can see bilateral SVC. This is a right SVC, this is a left SVC, and this kind of, and it's very, very important to show this systemic venous return when we assess the univentricular heart. Presence of a bilateral SVC, only thing it has to be kept in mind, because they will need bilateral bidirectional gland. This is a suprasternal view. You see there are multiple aortopulmonary collaterals, and when you see this kind of a multiple aortopulmonary collaterals, usually this kind of a patients definitely will need angiography prior to either a Glenn or a Fontan, because we have to coil embolize this accessory pulmonary blood flow, because that will increase your pulmonary artery pressures, and we know that eventually it's a risk factor for either a Glenn or a Fontan repair. So see to it that whether you are seeing these aortopulmonary artery collaterals, and if they are there, you have to definitely coil embolize them prior to Glenn surgery. Actually, this is this. I don't know why it's not working, but double inlet left ventricle, and this is a restrictive bulboventricular foramen. And this bulboventricular foramen, because you know your aorta comes from this ventricle, and it's restrictive, so it is causing your systemic outflow obstruction. And one is that. The second thing, when you have an obstruction at bulboventricular foramen, you will have hypertrophy of the left ventricle. It will keep on creating diastolic dysfunction of the ventricle, and again that's an incremental risk factor for long-term assessment of Fontan repair. So this suppose they have a restriction of bulboventricular foramen, there are a couple of things. Either you'll have to restrict this septum to make the bulboventricular foramen big, or if this baby presents to you in the early neonatal life, you will have to do something called as a BKS repair in this situation. So in addition to doing a bidirectional Glenn, there will be another procedures which may be required. We have to ligate, the surgeons will have to ligate small azygos. If the pulmonary arteries are distorted, they will have to do pulmonary arterioplasty. If there is a significant AV wall regurgitation, the repair of the AV wall is must. Eliminate the accessory blood flow, as I said, that we'll have to coil embolize these collaterals, and repair of systemic outflow obstruction if we have a obstructive bulboventricular foramen that has to be enlarged before doing the Glenn operation. And these are the procedures which are must when we consider univentricular heart repair, and therefore it's very important for us to show them adequately before doing the procedure. So as it's a standard procedure, it's a bidirectional gland. And I won't go into the hemodynamic details and what are the requirements, because we have another talk the next session, that what are the different procedures and what is the long-term outcome. But as we know that we have to connect the SVC to pulmonary arteries, and therefore the SVC pressure, the pulmonary artery pressure has to be definitely much lower than the SVC pressure, and so that it will flow, and we have a good transpulmonary gradient for the SVC to flow into the pulmonary circulation. Now you do a glension, and then we have to do a echo evaluation of a post glension, because I think you may have landed up in a situation in the ICU. You have a patient with gland but is swollen up, or if you have a patient with a gland who is significantly getting desaturated, and you will have to tell them what is the reason. So we know SVC is directly anastomosed to the right pulmonary artery. We have to image it in the suprasternal short axis view. Then, because it's a very low flow or a low velocity circuit, so you have to use very low velocity scale and low wall filters. And we many times see a pulse Doppler which shows a biphasic low velocity forward flow signal. So all that things is seen, and we have to keep on thinking. Suppose your patient is swollen up and not maintaining enough cardiac output, what must have gone wrong? Your SVC pressure is high. So why is the SVC pressure high? You may have a distal anastomotic narrowing which have to be shown on echo, or you have a pulmonary artery pressure little on the higher side, and therefore your SVC pressure also is remaining high, and your patient is swollen up because SVC pressure has gone up to 20. The patient will have definitely facial swelling. Suppose you have a patient who is significantly desaturating after gland, then what is happening? Sometimes if your pressures remain high, you have a decompressing vein from the innominate coming down. And on the suprasternal short axis view, you have to show that decompressing vein. So, as I said, a flow across the gland anastomosis, pulmonary artery distortion, decompressing veins because your SVC pressures are high, and another possibility, if the child is significantly desaturating, it's pulmonary AV malformations, and we know we can't see them on echocardiography unless we do a contrast echo. Actually, this was a 3D picture, and this is, you see, you have a SVC anastomosed to the pulmonary artery and without any distortion, and you see a smooth flow, smooth blue flow from the SVC going down in both the pulmonary arteries. Your pulmonary artery sizes are good, no problem. As compared to that, now you see, you have a SVC going into the pulmonary artery, but on the right side there is some problem. You have significantly narrow pulmonary artery, so your SVC pressures are high, and sometimes if the SVC pressures are high, you may see a decompressing vein coming from the SVC. One of the things which I was trying to tell you, that when we try to assess the ventricle by echocardiography, we always feel that left ventricle is a better ventricle than the right ventricle, and mainly because its fiber arrangements are different. It's the whole fiber arrangements are in such a way that it can generate a very good cardiac output. They are spirally arranged. If you see even the ejection fraction of the right ventricle and left ventricle, nobody knows what is the right ventricular ejection fraction, and we know what is the left ventricular ejection fraction. We say always it's a better ejection fraction. And when we try to see the coronary flow reserve, always the left ventricle has a better coronary flow reserve as compared to right ventricle, and therefore it can sustain higher pressures and obstructions. And therefore, always left ventricular morphology is better as compared to the right one, because for a long-term assessment of univentricular heart. Now the third stage, we know it's a completion of Fontan. It's a bidirectional gland plus conduit with multiple types, atrial, we have extracardiac conduit, and echo evaluation prior to fontan, as I said, is very important as prior to Glenn. And we have to see anomalies of systemic and pulmonary venous return. They are common with asthenia, polysthenia, systemic AV wall regurgitation. And we have to see the morphology of the ventricle, size of the interventricular communication, size of pulmonary artery and pulmonary ventricular function. How do we see the ventricular function in patients with fontan? Because we know ventricular volume overloading is a major concern because that's a single ventricle and that has to be preserved over the long term. We have to assess whether there is a, because when there is a single ventricle, usually it has increased wall stress and myocardial hypertrophy. It creates inappropriate changes in mass and volume, and ventricular hypertrophy is a major determinant of pulmonary blood flow because when the ventricular hypertrophy happens, it creates your diastolic dysfunction. When you have a diastolic dysfunction, you have an increased pulmonary artery pressure. And when your pulmonary artery pressures, your Glenn or a fontan is not going to flow. So it's a major determinant of pulmonary blood flow. And therefore, preoperative measurements of mass volume ratios are very important to assess that your ventricle is enough prepared to take the fontan circulation. What are the assessment of risk factors? If you have a pulmonary artery distortion, you have a pulmonary hypertension or increased pulmonary blood flow, significant AV wall regurgitation, reduced ventricular function, ventricular hypertrophy, complex systemic and pulmonary venous return, and especially if you have a little obstruction to pulmonary venous return, we have systemic outflow obstruction like restrictive bulboventricular foramen. These are all risk factors, or what is called as, if somebody is reading Kirkland's textbook, I really don't know, because we always used to read and there are always a description of incremental risk factors for a particular procedure. And in patients for a univentricular heart repair, these are always incremental risk factors on for a fontan completion. And the worst of them, if you have an increased pulmonary vascular resistance, your pulmonary arteries are distorted and your ventricular function is down. Rest of many times, if you have a complex systemic venous return as bilateral HVCs or interrupted IVC, it doesn't make much difference. But if your ventricular and pulmonary artery anatomy is distorted, your pulmonary vascular resistance is high, and your ventricular function is down, they are really significantly incremental risk factors for univentricular heart. Now this is like a diagram of a fontan completion, your IVC and SVC going into the pulmonary artery, and again we have to have a good pressure to flow into the pulmonary artery. So this pressure and the resistance definitely has to be low. Now you have a patient with fontan, and I don't know how many of you are regularly seeing them. It's very difficult to evaluate these fontan repairs later because they already have 2 or 3 surgeries before. They are becoming big. Their windows are difficult, and therefore, if many times, suppose they have any problem, suppose they are getting sinus or they are getting puffed up or the ventricular function is not good, the echo evaluation of fontan sometimes becomes very difficult because of difficult windows. If a conduit sometimes can be seen in parasternal or apical views, many times we may have to see do the TE, or many times even we have to do the MRI if you have to see the ventricles and the whole pathway. And you know, they are low velocity laminar flows. So this is a kind of IVC draining. It's a subcostal view, IVC draining into the fontan circuit. And many times you may be able to see, this is a short axis of the conduit. You may be able to see this conduit well, and if you see carefully, this is a fontan fenestration. Because sometimes you see these fontan patients coming with cyanosis. The cyanosis is not very low, but the oxygen saturations are in 80s, which you don't expect them, and especially they walk, the oxygen saturation drops. And one of the common reasons why this happens is we have a fenestration in the fontan, which is a little larger one and which has not closed over the period of time. And this is a view. This is a 4-chamber view. You have a single ventricle, and this is the short axis of the conduit, and you can see this fenestration in the conduit. So if you have a complication after Fontan and if you have to evaluate on echocardiography, suppose the patient has cyanosis, look for baffle leak or a fenestration, large shunt to the fenestration. Sometimes by mistake, if you have not demonstrated bilateral SVC, they just do a right-sided blend and your left SVC remains and which goes into the systemic circulation. You may still, in spite of completion Fontan, you may see some amount of a pulmonary AVMs which may be developed and you may have to do a contrast study for that. Effusions, the persistent effusions after Fontans are very common and sometimes why this happens, you have a little higher pulmonary artery pressures and pulmonary vascular resistance and your fenestration is very restrictive. Then you may have this effusions and you have to see the fenestration which is restrictive. Other complications which can be assessed very well on echo, pulmonary artery narrowing, systemic outflow obstruction, progressive subaortic stenosis, as we say, it is a restrictive valvoventricular foramen, pulmonary venous or systemic venous baffle obstruction, AV wall regurgitation, and poor ventricular function. So these all things need to be assessed in post-Fontan repairs when they come to you for a follow-up on echocardiography. So abnormal patterns, when do you see when there is a reduced ventricular function, when you have a predominant diastolic flows in the pulmonary arteries and loss of normal respiratory variations. So these are abnormal flow patterns of in pulmonary artery when you put a Doppler evaluation. Unfortunately, as I said, these are not seen. This is a kind of a subcostal view, and this is the IVC, extracardiac Fontan, and this is a device which has been put and it's closed. So on echo evaluation, sometimes what we see which are probable unsuitable candidates in initial evaluation on Fontan, I won't say sometimes they are non-suitable, but very high risk candidates, and this assessment has to be done on echocardiography. If you have a univentricular heart, pulmonary atresia, non-confluent or very hypoplastic branch pulmonary arteries, because this is the key. You need to have a good size confluent branch pulmonary arteries for a good Fontan in future. So if you have a univentricular heart, but pulmonary atresia, multiple collaterals, non-confluent hypoplastic branch PAs, we have severe AV wall regurgitation, we have dilated ventricle with poor function, and severe pulmonary artery hypertension presenting first time at a later age. So you have a 5-year-old boy with a double inlet ventricle and severe pulmonary artery hypertension, and whatever you try to do, you will never have normal pulmonary artery pressures even if you do banding and anything. So in your initial evaluation on echocardiography, if you find any of these subsets, I think many times whether really you want to push them for a univentricular heart repair because they are probably not suitable candidates on initial evaluation. So at nutshell, I think echocardiography forms a very, very important tool on initial assessment. We know many of these patients may need some additional imaging either by CT, MRI, cardiac catheterization for multiple things, because not only imaging is important, the hemodynamics and pressure measurements and measurements of pulmonary vascular resistance is equally important in these patients, because we need to have accurate PA pressures and PVRI and left ventricular end diastolic pressure measurements. And I know many centers still prefer to do, including ours, to do a cardiac catheterization, especially before Fontan. Sometimes if you have an adequate anatomy, just on echocardiography also, we may be able to take them for a surgery for a Glenn, but pre-Fontan, definitely everybody needs additional assessment prior to surgery. But echocardiography forms, I think, the initial assessment tool. So thank you very much, and sorry for some of the videos which really didn't work.